My name is Alejandro Diaz. I'm a pediatric endocrinologist at Nicola Children's Hospital. And I'm here today to discuss with you thyroid function tests in pediatrics, what tests to order, when to order them, interpretation, and early approach. You can ask any questions that you have in the YouTube chat. First, I'm going to start with the physiology of the thyroid production. And basically, can I get the first slide, please? Basically, the TSH, the thyrotropin, stimulates the follicular cell. TSH increases the absorption of iodine inside the cell and also stimulates the synthesis of thyroglobulin. Iodine goes inside the lumen of the thyroid, and in the lumen it gets attached to tyrosine molecules via the thyroid peroxidase. Then this complex is going to go back into the cell by endocytosis, and by the stimulation of TSH, it's going to be liberated into the capillary. Here we see all the problems that you can have in the thyroid function, thyroid production, like antibodies against thyroid peroxidase, problems in this hormogenesis that I'm going to mention later. This is a little figure that shows how the thyroid function works. Basically, we produce TSH, thyrotropin, in the pituitary gland due to the stimulation of TRH, and then TSH goes to the thyroid gland and produces a stimulation of the production of T4. 85% of the thyroid production is T4, and T3, 15% is T3. The active form in the periphery, in the tissues, is free T3. Then there is a conversion by deiodinases, and the free circulating forms are only less than 0.5% of the thyroid levels in circulation. When you have damage of the thyroid gland due to an autoimmune reaction, like in Hashimoto Thyroiditis, you have thyroid peroxidase antibodies, thyroglobulin antibodies, and they produce damage of the gland. Then you decrease the production of T4 and free T4. There, the thyrotropin, the TSH levels are going to go high. Then you have high levels of TSH in primary hypothyroidism, by far the most common cause is Hashimoto Thyroiditis. Or if you have a stimulation of the receptor for TSH due to antibodies that stimulate, because you also have blocking antibodies, then you have increased production of T4, T3, and decrease of TSH levels. When you have a problem in the hypothalamic pituitary area, you are not going to be able to produce enough TSH to stimulate the thyroid gland, and that's called central hypothyroidism, which is quite rare. Mainly those patients have other central nervous system problems. And in those cases, you have low TSH, normal TSH of a slightly elevated TSH, with low T4, free T4, and T3. Then I'm going to review the thyroid tests. Therefore, you have an idea of all the possible tests that we order and which ones are important from the clinical standpoint. The TSH thyrotropin is the most important test. In adults, usually practitioners only check for TSH. And I believe if you are checking a normal child with some minor symptoms, you can use TSH alone, and it will be a good test. TSH peaks early morning, and in the afternoon, the levels are far lower. The difference is 1 to 2 microinternational units per milliliter between early morning and evening. Then it's quite significant to keep that in mind. Free T4 is less than 0.5% of the hormone in circulation. It's very important because it's more reliable than free T3, and that's a test to check. The problem is that the immunoassays, the test is not so good in itself. Then you may have some borderline high or low levels, and because the test is not so good, it is not so reliable. Then you need to use the clinic to have an idea of what's going on, or order the test by equilibrium dialysis. Something important about the free T4 is a very small change in the free T4 produces a big change of the TSH. For example, if TSH drops from 1 to 0.5, TSH is going to go from 5 to 50. Therefore, it's a logarithmic relationship. T4 and T3 are bound to thyroxine binding protein, transretin, albumin, and it's a good test. The problem is that if you have anything that affects the levels of TBG or albumin, then the levels of total T4 and T3 are going to be affected. The best example are birth control pills. Women on birth control pills have high levels of T4 and T3. The free T3, sometimes I order free T3 when I want to see the degree of hyperthyroidism in a patient with Graves' disease usually. Reverse T3, we use them for patients in the intensive care units, because if you have a low T4 or low free T4 or a low T3, normal TSH, a little bit low TSH or improving TSH, but you are not clear what's going on with the patient, then reverse T3, if that's high, it tells you that the patient has CQ thyroid syndrome or non-thyroid illness. Then that's important to clarify the diagnosis. However, clinically, we know what's going on most of the cases. The best example are my patients in severe DKA, diabetes ketoacidosis, who have all the levels low, or the T4 low, T3 low, and the reverse T3 is going to be high. T3 uptake helps to determine the thyroxine binding globulin levels. Then if we have low levels of TBG, the T uptake is high. The free T4 index is also is a measure of T4, free T4 levels without the binding proteins. Thyroid peroxidase antibodies are very important because this is the most remarkable test to determine if a patient has Hashimoto Thyroiditis. Hashimoto Thyroiditis is quite common, affects 1 to 2% of children and 5 to 10% of adult women. Therefore, thyroid peroxidase antibodies is the test to order if you find a goiter or if the patient has subclinical or clinical hypothyroidism, an elevation of TSH more than 5. You should repeat the test. You can wait if it's between 5 and 10, a few months, but the thyroid peroxidase antibody is very important. When the patient has hyperthyroidism, then the test to prove the diagnosis, you have low TSH, high T4, high T3, but the test to determine if the patient has Graves' disease, that is the most common cause of hyperthyroidism in children, is the antibody. Also, the TSH receptor antibody helps in those cases of congenital hyperthyroidism, or when the mother has Graves' disease, because there is a good chance that the baby is going to have Graves' disease and can be a very serious condition. Then if you want to be safe, you check the levels in the child, TSH, free T4, and the antibodies. If the antibodies are high, even though the TSH and free T4 are normal, that patient needs to be followed with tests once a week until the antibodies are negative. Thyroglobulin is important laboratory test to follow up in patients with thyroid cancer. After total thyroidectomy, the thyroglobulin levels should be undetectable. Antithyroglobulin antibodies, we use that in combination with the thyroid peroxidase antibodies. However, the clinical significance is questionable, but it's very important in the follow-up of patients with thyroid cancer. And calcitonin is a test ordered for evaluation and follow-up of medullary thyroid cancer. Remember that congenital hypothyroidism is quite common, affecting 1 in 2,000 babies in general. The diagnosis is usually made by the newborn screening. The problem is that if the baby was premature or was very sick, then it's possible that the newborn screening is going to have a false positive. And if you have a level, high level, usually more than 30 or 40, you should start treatment with levothyroxine, 10 to 15 micrograms per kilo per day, and repeat TSH, free T4 immediately before or starting treatment. Therefore, you don't need to wait for the results to be back, because remember that the IQ of the baby may be affected. If the level is between 20 and 30, between 15 and 30, then you can wait to repeat the newborn screening. If the patient has hypothyroidism, the baby has hypothyroidism, you should order a thyroid scan or a thyroid ultrasound, and there are pros and cons for each one. This is very important to see this table here because you can see the levels in the first week of life of newborns. And you can see that if you do the newborn screening, the first 48 hours of life, the TSH is likely to be high, and you may have a false positive for hypothyroidism. It's important to see here also that at 7 days of life, the TSH is normal up to 8.3. And if 8.3 is generally considered normal, or 8 is generally considered normal the first year of life, 8 to 10, then you don't need to treat kids in the first year of life with a TSH less than 10. Later in life is questionable. And you can see also how the free T4 levels in a newborn are higher than in older kids and adults. Just to keep that in mind, that a free T4 of 0.9 may be normal for another person, but not for a newborn. Then, I'm going to discuss 2 or 3 of the most common conditions in pediatrics for you to have an idea what the approach should be. Then, Hashimoto Thyroiditis is the most common cause of hypothyroidism. Usually, the patient is identified because you find a goiter. The problem is that thyroid peroxidase antibodies are positive in almost 15% of euthyroid females. That's quite high. Thinking that hypothyroidism happens in less than 1% of the population, and 8% of euthyroid males. Therefore, many people are going to have positive antibodies without having hypothyroidism. And once you have positive antibodies, TPO antibodies, the chances to have hypothyroidism in the future is more or less 2% per year. That's the reason why any child with Hashimoto thyroiditis, I do TSH and free T4. You can do TSH alone, it will be okay, every 6 months. And once they stop growing, I do it once a year. If the patient has subclinical hypothyroidism, meaning TSH between 5 and 10, or 4.5 and 10, with positive antibodies, the risk of developing hypothyroidism is higher, it's around 4% per year. Antithyroglobulin antibodies are positive in 10% of the population, and it's not as specific and sensitive as the TPO levels, and basically it's not so important to determine the patient has thyroid disease. Graves' disease affects around 1 in 10,000 people in the US. It is higher in other countries. It's lower the incidence, like in England it's only 1 in 100,000, but here in the US it's 1 in 10,000. The most common age is between 10 and 15 years, adolescency. It's more common in patients with trisomy 21, with Turner syndrome. I have a good number of patients with Graves' disease and trisomy 21. And the clue here is the patient has, clinically, you can't miss that, high heart rate. If you have a child who has a resting heart rate more than 90 over 100, please check TSH and free T4 levels. Most of my patients with Graves' disease have been in the ER a couple of times, or the pediatrician, and the heart rate was high, and they were missed. And if you have any child with a heart rate more than 90, 100, 110, palpitations, psychiatric conditions, anxiety, problems sleeping, then please check TSH and free T4. And the TSH is low, free T4, T4 are high. Then you check the TSH receptor antibodies. That can be the blocking one called TBII, and that's a cheaper test to order, or the TSI, that is a specific stimulating antibody, and that's for more expensive. In general, I order TBII because it's cheaper, and if it's positive and the child has hyperthyroidism, proves the diagnosis of Graves' disease. You can have other causes of hyperthyroidism, like hashitoxicosis, early stages of Hashimoto, where you produce T4 and T3 because the thyroid has been damaged, or thyroiditis, or active nodules, functioning nodules, which are not so common in children. But always in kids with hyperthyroidism, I order a thyroid ultrasound to be sure that they don't have a thyroid nodule. When to check thyroid function tests? If you have a patient with a goiter, of course. If you have patients with mood changes or psychiatric problems, in the psych units, they always check TSH and free T4 when the patient is admitted initially. Hair loss. Hashimoto thyroiditis per se doesn't produce hair loss. It's hyperthyroidism. The thing is that if you have Hashimoto thyroiditis, you have more chances to have other autoimmune conditions, and that's what may be affecting the hair. Fatigue, low energy, new-onset constipation, dry skin, palpitations, anxiety, tachycardia, as I mentioned before, unexplained weight loss, rapid growth without puberty. But it is not recommended by the last guidelines of the Endocrine Society to check routine thyroid function tests in children with obesity or overweight. For me, the clue is growth velocity. If the child is growing well, I don't expect the child to have an endocrine problem to explain obesity or any other conditions. Then this is an algorithm, what to do, how to do with the interpretation of the thyroid function test. If the TSH is high, then you look at the free T4. If the free T4 is low, then the patient has primary hypothyroidism, more likely due to Hashimoto thyroiditis. In other countries, iodine deficiency, or of course, patient who has surgery or radioactive iodine due to Graves' disease or other conditions. And this is straightforward. If the TSH is high, but the free T4 is normal, we call that subclinical hypothyroidism, usually TSH between 4.5 and 10. If the TSH is more than 10, in general, we treat the child unless the child was sick, and we believe that the child is recovering from a CQ thyroid syndrome condition. Very important for you to remember is that the most common cause of subclinical hypothyroidism in children is obesity. Remember that around 30% of children in the US are overweight or obese. Then what I do is I check the TSH with the thyroid peroxidase antibodies to be sure there's no Hashimoto thyroiditis. And if it's no Hashimoto thyroiditis and the patient doesn't have a goiter, then I know that likely they are going to improve just with weight loss. Around 50% of people with subclinical hypothyroidism are going to recover from the condition, and around 4% of them are going to develop overt hypothyroidism. If the TSH is high and the free T4 is high, then maybe an assay interference. Remember that there are some antibodies that can affect the reading. To have high TSH and high free T4 doesn't make a lot of sense in general. However, you can have a tumor in the pituitary producing TSH, but that's extremely rare. It's far less than 1 in 100,000 people. Or you can have something that is called thyroid hormone resistance. Endocrinologists know that as a Refetov syndrome, where the TSH receptor with the T4, the T4 receptor, the T3 receptor is not working well, then the child is going to have high TSH, high T4, and sometimes they have peripheral symptoms of hyperthyroidism, like increased heart rate, and may have central symptoms of hypothyroidism, like lethargy, low energy. However, that condition is very rare. When you have high TSH and high free T4, I usually, as I mentioned before, think that there is a problem with the assay for free T4, which is not so good. If you have high TSH and you have low free T4, then the first thing you think is secondary hypothyroidism, pituitary tumor, craniopharyngioma in children, history of pituitary surgery or radiotherapy. This condition is not so common as a primary condition. Often they have other pituitary deficiencies. Then if a newborn has jaundice, micropenis, then in those cases I think about central hypothyroidism. If the TSH is low and the free T4 is and the free T4 is normal, we call that subclinical hyperthyroidism, and usually it's benign. However, I always check for the TBI antibodies, and I always do a thyroid ultrasound to be sure that I'm not going to miss a nodule. Then TSH low with normal free T4, subclinical hyperthyroidism. Some people have subclinical hypothyroidism for their entire life and they don't have clinical problems. If the TSH is low and the free T4 is high, then you think about Graves' disease, primary hyperthyroidism, Graves' disease, toxin nodules producing T4, T3, or thyroiditis. Hashimoto thyroiditis can produce a period of hyperthyroidism at the beginning. Then what are the special situations where you need to pay attention or the tests look different? One is very important. If there is maternal history of hyper or hypothyroidism, it's very important. Maybe when the mother has Graves' disease and has been treated with PTU during pregnancy, to check in the newborn TSH, free T4, and the antibody, the TBII or TSI antibody. If the tests are normal and the antibody is negative, you don't need to do anything else. If the antibody is positive, this patient needs to be followed. I do once a week thyroid function test, and I repeat the thyroid antibodies because they may develop hyperthyroidism in the first few weeks of life and can be a life-threatening condition. Failure to thrive, sometimes they have a goiter. Then, problems with the laboratory, as I mentioned before, there is something called heterophile antibodies, a rheumatoid factor, which affects TSH levels, and then they have low or high levels of TSH without having a problem. What I do in those cases is I order TSH or thyroid function test in a different laboratory to find out if the problem is the assay of the Quest or LabCorp or any laboratory. If you are taking biotin, high doses of biotin, the laboratory tests are going to look identical as in Graves' disease. Low TSH, high free T4, and the antibodies can be positive, the TBII or TSI antibodies. And this is very tricky because you may be tempted to treat the child, or what you do is just stop if the child doesn't have an increased heart rate and doesn't have any clinical symptoms or signs of hyperthyroidism, you stop the biotin and repeat the test 1 or 2 weeks later. And medications. We know that dopamine agonists, glucocorticoids, somatostatin analogs for people with inflammatory bowel disease or some tumors, they produce low levels of TSH. Furosemide, aspirin, phenytoin, heparin produce higher levels of free T4. And the most common that we see in adolescents is high levels of total T4 or T3, and that's secondary to birth control pills. And there are conditions that are well known to produce hypothyroidism: lithium, tyrosine kinase inhibitors, and amiodarone. Amiodarone can produce hypothyroidism and also hyperthyroidism depending on the iodine levels of the patient. Okay, I'm gonna look now at the questions that you have been sending to me. And I don't see any questions. My email is alejandro.diaz@nicholashealth.org. If you have any questions or any comments, please send me an email. I'll be happy to reply to you. Thank you so much.